Thank you. We're going to get started, although Dr. Trabal is listed as the moderator. It's occurred to me that he might not have seen that or remembered. He is here loading his slides, and Dr. Chopra is going to give us the first two talks, and then Dr. Hunter, and then we'll have the talks from Dr. Trabal, and it's all kind of in the area of AV fistula work. So thanks, Romy, for agreeing to do these two talks. And if everybody's comfortable where they are, that's fine. Otherwise, you can shift to be one group, whatever you like, and we'll go ahead with these talks. Thanks.
Thank you.
Thank you.
Awesome, thank you. So what I did, Patty had asked me to do two different talks. One was about tips and tricks. And there's so much to talk about. And another one was whether nitinol bear stents or whatever bear stents are better than, or what's the comparison with covered grafts. So what I thought I'd do is combine this together, and I had some other presentations before. So I'll do a quick kind of run through, which have different techniques, procedures, and stuff. And is there a timer so I don't go over time? There's no, oh, there it is. I see it now. So I have 25 minutes, so we'll go from there. So we're talking about all the different things that go in. And one of the things that's happening in dialysis, how many of you folks do dialysis access right now? Okay, so one of the things that's happening in dialysis, if you haven't realized, is that whole business of dialysis access is being reorganized. When Fresenius has bought many access centers, nephrologists are doing any access. Any nephrologists in the audience? None here. So the interventional nephrology has grown. They control the patients. So the dialysis center, Fresenius is one of the biggest ones. Next is DaVita. They all own that. They're partnerships. So those patients are being tracked and kind of into their centers, outpatients. So there's all the sands are shifting. But the bottom line is that it's a business, and like any business, must add value. And the government sees this as the diabetic population is growing, this disease entity is growing, access costs are the largest, and it is so fragmented. If you have a relative or somebody who's had dialysis, is on dialysis, you will realize that very soon how messed up it is from the patient's point of view. So all businesses must add value, and a business does not have the right to exist if it doesn't add value. And this is the Walmart era of doing things faster, better, cheaper. So those economic forces are driving everything else. And obviously, all activities are geared towards meeting human needs, and everybody wants to live as long as possible, and while they're alive, wants to have the best quality of life. And dialysis is no different. So we've kind of been working towards more of a collaborative model, if you would. It's hard. It's not that everybody's under one ownership, but we collaborate in all the different places. So we make sure that, for example, I have folks who will actually even go to a patient's house, go to the dialysis center, make sure we have their issues resolved. And access is the biggest hassle for dialysis patients. So when we do that, we're working with a lot of different patients. We provide transportation, but there are rules against certain kind of transportation. We work with hospitals, we work with outpatient centers, et cetera, that go into. And the key here is keep the plumbing open and at the same time keep the cost down and meet all the regulations that's going on as well. Catheters, as we know, there's catheters, but the issues with catheters, the only reason I put this up is there are a lot of issues that pop up. And if you still have folks in your hospital putting central lines from the subclavian, you got to knock them on the head and say you can't do that. If you have diabetics, pre-renal, who are getting PICC lines, it's a problem. The folks putting IV, so follow the KDOKI guidelines, because this becomes their lifeline, and it's extremely crucial that these things are looked at. And then obviously there are issues about fistula first, and one of the things that has started to happen is that, yes, fistula first, and there were a lot of fistulas being put in, but there are certain types of patients who are not good candidates for fistulas. So we'll ended up seeing a lot of patients going back to either catheter or to grafts, or we started doing a lot of balloon-assisted maturation, which is a new thing. So not that new, but relatively new. So now the nephrologists have become very attuned to saying, hey, can you mature this fistula for me? So I'll get a call saying, we put the fistula in, get the a central line for us, but also what can you do to mature the fistula, and things go for us. But these patients get tortured. I had an uncle. That's how I first got even more passionate from the human side of this, was For my aunt, who was very close to it, is absolute torture. They're bouncing at 4 in the morning to dialysis center. Then if something goes wrong, you go to a surgeon, you go to an ER, you go to a hospital, you get admitted. Who knows what's happening? You go to an IR, et cetera, it bounces all over the place, and there's no central coordination. And this is one of the things that the data is out there, that even with fistula first, the fistulas grew, grafts declined, but catheters stayed flat. And why was that? And one of the issues was, as we talked earlier, there's certain candidates that are not really candidates for fistula. So balloon-assisted maturation became one of the things. And obviously, when you look at grafts, and I'm kind of throwing in those two talks together, but when we talk about bare metal stents as well, and the idea is to keep the circuit open versus just looking at target lesion and what's the patency there, et cetera. So at any given time, what dialysis is all about is getting good flow and managing flow from there. And venous outflow stenosis is the biggest problem. But we used to do a lot with grafts, and I'm using this only for the discuss the idea about bare stents versus stent grafts. Bottom line is our stent graft use has grown tremendously because we're finding ways to keep these things open much further. In this example, what we're really doing is taking the graft and converting it into a longer graft, where there's a venous outflow with the endograft on the inside. But there are certain surgeons who believe that they would convert that to an AV fistula instead of doing outflow work. So it really depends on the model where you are. Are you with the surgeon working with you as well? But the bottom line here, and I'm going to go through this just a bit to kind of retouch on the topic as well. So what idea is you want to avoid hospitalization, and now Medicare denies payment, nephrologist is punished for it, the dialysis center is punished for it, so hospitalization is a challenge. There's a lot of various devices that could be used, but hospitals watch this like a hawk now because the cost keeps going up. We've been using TPA forever. Excuse me. So we've been using TPA forever, and I stay away from expensive devices. You take a little 8 milligrams of TPA and you kind of do the lice and go technique, if you would, which we'll talk about. And then, we try to avoid. We know that the patency with balloon angioplasty is not that good long term. It's like in the 30% range, plus or minus, depending on what paper you read at. But the bottom line is at 6 months, you're going to have some problem with an AV graft. So the way I look at it, the analogy is AV fistula takes a while to mature, but it's like having a good relationship. It takes a while to mature, but once it's there, it lasts a long time. So fistula, when you put it in, may take a while to get going, but once it goes in, I've seen patients with 6 and 7 years, we've kept their fistula going. Grafts, on the other hand, use them immediately, but 6 to 7 months, you're going to have some problem. You come back, you fix them, another problem, and that's the thing. So we're seeing less and less of these grafts, without a doubt. And hospitals are being penalized, dialysis centers get penalized, the surgeons are encouraged to put more AV fistulas in as well. But the bottom line, plumbing, keep the circuit open and get going. This is just saying that you use TPA. Cinnamon et al. Have described the lice and weight, some folks in the graphs if you do much. But we've kind of had this lice and go thing. We put in the TPA, it's a tube full of clot. I pulse it, I know there's a venous stenosis. I'm going to give some heparin. I can do this in about 15, 16 minutes, whole procedure, start to finish. So we get in, we know there's a stenosis. Sometimes I don't even do the venogram. I put a balloon right up there. I plasti it, I pull the arterial plug in, I got flow going in, I've plastied both ends, and then I do the venogram. Once I got flow going, then it's all set. If there's a venous outflow, whether it's central or just the vein, whether it's cephalic or basilic or brachial, I'll angioplasty that and then go from there. For closure, we just do a purse string suture. So it's been kind of now become standard. We've been doing it for years. It's very effective. The routine stuff that you can, there was one patient I had that we used a mechanical device that I think the clot was kind of such tiny particles. He got some massive pulmonary embolism and coded right there on the table. But coming to the key topic of how do you deal with the edge stenosis? So angioplasty alone, after a while they're going to come back. They may look good, but clinical success means you put your hand on the fistula and you get a thrill or not, or the graft. If you get a thrill, then you got clinical success regardless of how it is. Sometimes it looks good, but you don't get a clinical thrill and you still have a pulse. Then you know that there's still some problem there. But the other thing is there's elastic recoil. And sometimes it's not immediate. It may happen a little later. And some folks believe you do it, you send them back, they come back again. But now there are 90-day global periods involved as well. So again, any way to cut down the payment. So at that time, we've become more and more keen to start stenting this. Earlier we used to put bare stents, but I showed you that picture of how you get intense intimal hyperplasia. So then we started moving to endografts. And my personal preference is the Viabon only because it's actually a graft with a little lining on the outside of nitinol, versus it being a stent covered by a material, or some of the other ones where the stent material is on the inside. And that's kind of the issue. So and it's also extremely flexible, so around whether there's elbow movement, et cetera, that it really works fairly well. Long stenosis like this, and you can land up doing it over long segments that you can keep this going. All right, we'll move to this a little bit. But just to show you how, with bare stents, within 3 to 6 months, you start seeing intense restenosis again. And for these patients, the idea is open the pipe, keep it open as long as possible. And we've started to put these even, pseudoaneurysms, which I'll show you in a bit, but we've started to put them all the way. I've got one patient that literally from all the way down by the anastomosis where it started, all the way up to the cephalic arch, so it's just an extended thing. So you might wonder, how do you manage with surgery if something had happened? Interestingly, it comes out very easily at surgery, which my surgeon partner showed me so. All right. Now, in terms of endograft, there's more and more data coming out, but as far as if you have a graft, then the 6-month patency is better than angioplasty, but it's not something that at 90% or something. It's all around the 6 to 8 month period at 50 to 60%. So we use them to salvage access. We'll look at the outflow. We will work with the surgeons not to compromise further access creation. So the way I look at it is you have a patient, you want to give him an access that lasts for a good 5, 6, 7 years with no messing around, if you can. If you do that, then life becomes really good for them. There's several types of endografts, as you know. I mean, the way I look at it is a stent covered with graft is a covered stent. If you have the types of stents where there's metal exposed on the outside, personally, I don't prefer any metal touching the vessel because that's what I believe incites the intimal hyperplasia and causes it. Now, grafts have been used, PTFE has been used forever. And in the PTFE, if you look at the Viabon, which unfortunately is the only one out there, but also it's a very good product, you can see that this PTFE has this lining on the outside just like an exoskeleton, but really it's the same PTFE that is done surgically. So in a way, it's a graft on a catheter, the same graft on a catheter. All right, then, we've put them across all kinds of junctions, elbows, convoluted. We've done some pretty aggressive work. One of the things we were doing was repairing pseudoaneurysms, and I know there's a talk coming up, but this is something which was more like a combined procedure right in the cath lab. We would put a Viabon, exclude the pseudoaneurysm, and then excise the pseudoaneurysm right there. And you can see this one ready to rupture with all the bleeding, et cetera, post Viabon. You can see it's pretty neat. And these endografts, I know they're working on stuff that can be punctured immediately, but we've had dialysis centers puncture these routinely, and they've not had problems with that. One of the things with pseudoaneurysm, when you exclude it, I used to not believe in giving antibiotics, and the ID guys would always stop us from giving precautionary antibiotics, like a gram of Ancef or so. But the blood that is now excluded in the pseudoaneurysm, it tends to collect bacteremia, and we've had some infections. Initially, we thought it was just poor hygiene or technique or whatever, but we've learned to evacuate the clot around the pseudoaneurysm. And because the other problem they'll have is palpating the graft underneath to access it, and then they start poking within the aneurysm, and the nurses in the dialysis center don't really know much about it. So this is just to show you that combined process, if you would. So, we've done the venogram, you see the huge, let me go back. You see the pseudoaneurysm, we've excluded that whole thing with the Viabon, and then at the end, after we've excised it on the outside, you can see it's now converted into a graft, if you would, and at the same token that there's no pseudoaneurysm. and we just trim that right in the cath lab. And these are already rooms anyway, but you do the right precaution for the patient. It's a huge savings because the cost in a hospital, a cath lab is way less than an OR. And I don't know why, but hospitals will figure that at some point. And so this is all done in one procedure, so to speak. Now, if you put bare stents, be ready to see this in 3 to 6 months coming back in various different. So we see them in the clinic. I think it's against Medicare rules to just go ahead and just do venograms routinely 2 to 3 months. There should be a clinical evaluation and then decide to do a venogram. Just scheduling for venograms, you can get into trouble because it's not an indicated procedure. So, but you start seeing stenosis like this. We routinely, you plasty it, you're going to see because it's really fibrotic. You see some rupture. So now we routinely vibe on these things and keep good flow going through that. So we've gotten to a point where now we try to do comprehensive dialysis access management. It's not about how many tricks and things you can do and how fancy the procedure is. It's really about keeping good plumbing open for these patients, make their lives very easy. We follow them very aggressively. We actually have folks who go to the dialysis center. We know they're going to be there Monday, Wednesday, Friday, or Tuesday, Thursday, Saturday. We will check them at that time. Interestingly, we do all a PAD screening on them too. We have like a socks off program, if you would. We make sure that they check the patient's pulses. If there are issues, we check that. And then we're always in touch with the nephrologist, the surgeon, and obviously the interventionist. Now, what we've started to see, because some of our work is hospital-based, and a lot of these centers are now attached to a dialysis center where the interventional nephrologist is doing it, but they don't want to do the very high-end, complicated stuff. So instead of these patients getting lost in the mix, we've started working with them, saying, all right, you do the basic stuff. It's okay. You declot them or whatever. And then as you need stuff, a central stenosis, et cetera, whether it's economic issue, a skill issue, come there, we'll do it. We'll send them back to them and kind of work our way from them. So obviously there's a lot of focus on this. Another big focus is if you manage the access well, then you start helping the dialysis center reduce the catheter prevalence rate, and dialysis centers are obviously rewarded or punished based on that. So I'm not a surgeon, but I'm classified as a champion surgeon for these centers because we manage these very well for them, the access, we keep the flow going, and we keep them catheter free as much as possible. We do the hero grafts with the surgeon, we do all the balloon-assisted maturation, we bring them through that, and more importantly is a very active surveillance program to keep sure that the access stays good. There is a big movement coming up towards PD catheters. I don't know if there's a discussion here or not today, but more and more of these, and the other thing that's popping up, especially in countries where the economies can't handle this kind of cost, PD is huge, but also home dialysis is huge. That is starting, and that movement is starting to come up here as well. So, well, thank you. Any questions? I want this to be more of a discussion if possible. We have about 5 minutes to fill in on some of these. Any questions at all? So, hi, how are you?
Hello? Okay. Thank you, Dr. Mutajame. I have a question. What would you consider proper routine surveillance?
We do surveillance, but what we don't do is routine venograms. Because economically, by law, Medicare sees that as fraud. But you can actually, you examine the patient, you can check their flow rates, check their venous pressures. If everything is fine, they don't need a venogram.
Okay.
But if there's, for example, you just examine them and you feel a pulse where there should be a thrill, there's some venous outflow. But if their pressures are high or their clearance rate is not good and the dialysis center tells you, then you schedule them for a venogram. Because routinely earlier we had like 1,000 patients and we were doing venograms every 3 months at a large academic center. So each patient got 3 venograms, which let's say were normal, or even 2 out of those 3 were normal. You did 2,000 studies that were not necessary. Now you multiply that across all the cities and look at Medicare looking at this. So it became very clear that you should have a proper indication to do this. So that's very important to know, because most fellowship programs taught it, the fellows learn it, they go to the center and they do it. We were cautioned not to do that because we were doing a very high volume. Question there.
You know, at Iowa, they had a very successful program of monitoring resistance and recirculation at the center.
Yes.
And as soon as the resistance, venous resistance went up or the recirculation times in the grasp, they just immediately call and troubleshoot those. And then they cut back and they took, you know, they couldn't afford the people who were like doing that kind of data analysis or watching that. And sort of everything went to pieces. It seems to me that that's a very cost-effective way of managing these fistula.
Yeah, so, yeah. Actually, did you want to say something? But what we've done is, in the way we've dealt with this is, I actually have a dialysis access coordinator. Now this has changed in the last year and a half, but at one point we were serving over 45 dialysis centers from a wide area. And we had a central number that they would call. So it started at 4 in the morning when the first patient shows up. Any minor issue, so they do the dialysis, they see, you know, the venous pressures are high, and we taught all of them. We go for their QA meetings. Our coordinator would travel to all these centers, and then they would get set up. So we created a form for them to say, what's the problem, what's the issue? If there was any issue, they were shipped out. To make it convenient for them, we would do the H&P and the evaluation, let's say at the outpatient center of the hospital, on the same day suite. If we felt they didn't need anything, we can send them back, but not just routinely schedule these patients. So we were as effective now, just that the dialysis centers got the money cut, so they were trimming costs as well. So they replaced a lot of these. The other thing we used to do was ultrasound, but ultrasound is not paid for either. And if you have a lot of patients, you do a lot of ultrasound and don't get paid for it. So a clinic visit, paid for. And so you have the resources for it. In the clinic visit, you evaluate and see how they're doing. And then you see if there's any pulse along the, so the clinical exam becomes really important, and that's another way to survey them. So we do the surveillance, but we don't do routine venogram surveillance, which is a waste of resources.
You know, where I am, it's very difficult will be very difficult for me to routinely see these people in the office. And what ends up happening is that either they, like Dr. Thorpe said, they either realize there's a problem with the machine, or they touch it and the nephrologist touch it and feel something wrong, and then they come to me. So it's hard, because it would be nice to have like a standard on how we should evaluate these fistulas.
Yeah, I'll tell you what we did with that. Was I had PAs, and the PAs can do the consult in the dialysis center. So we used to round on them. If there was a problem, they called us. If not, we rounded on them. Now, obviously, with the reimbursements dropping, you got to find a way to somehow manage your cost. But the point was, regardless of who does it and where you do it, you want to do clinical surveillance. And if they have an issue, because sometimes we had patients, like on a fistula, we fixed it, they're doing great. But they came back and they're getting punctured and they're getting venograms. And there's a hospital stay involved, or if they came same day, a lot of them are diabetics, a lot of them are nursing homes, a lot of them don't have home care, they are solo transportation. The cost is huge of just doing a venogram. And what you don't realize is hospitals charge a lot of money for all the ancillary stuff in addition, and cath lab time and all this stuff. Some of the bills are huge, $20,000.
I'll just throw this out, but it seems to me that both of somebody could figure out how to have a bracelet. Because it's funny that patients have always said, geez, the pulse was so great yesterday, and they don't understand this water hammer pulse phenomenon banging against an outflow stenosis that suddenly drop off the last time they dialyze. So why couldn't they wear a bracelet that actually qualitatively told them, or we can make some interpretation from the quality of the flow and the quantity of the flow that the fistula was going south, either because of arterial inflow problems or outflow problems. It just seems like something we could make. And every outpatient in the country can go home with the money. It might be personalized to them, but
That's a great idea, actually. It could make a lot of money, Pat. You better patent that quickly.
that's my deal.
There you go. No, but you know what I do is, we spend a lot of time educating the patient or the caregiver about feeling their and monitoring themselves. So I teach them. I say, when they come in, I said, you see, you don't feel anything, or you got a pulse, And then I tell them, okay, we've opened it, now feel it. Do you feel the thrill? Is a buzz? And we make jokes around it, see it's a thrilling feeling. But the idea was to play around enough with the topic so they learn it. And then we had patients who say, doc, you taught me last time, and now actually that thrill went away, and I knew something was wrong. I kept telling the nurse, she said, oh no, your dialysis is okay, but I said, no, something's wrong. And then they come to the office. Or we'll tell them, okay, we'll see you at the center, and one of my coordinators would see them, or my PAs would see them, or would get them to the same day and examine them there. Because it's easier to cancel than to not do anything and then have them thrombose or be without dialysis. Because the other thing that has happened is, earlier, you waited, they got shut down, now it's Friday afternoon. Or even if they found out Friday morning, there's no lab that's going to take them right now. And then earlier they used to just be sent to the ER, but now ERs won't take them. The hospital won't admit them. The hospital does not want a cath lab team coming in on the weekend. They're watching their costs very aggressively. So some of these patients will stay till Monday. If they stay, fine, but they'll end up getting critically ill on a Sunday. Now they're getting admitted. And now you got pulmonary edema, you got fluid overload, you got all these problems. So this surveillance really helps. So our volume of declotting has tanked dramatically. One is because we're doing the surveillance, two is we've taught them, and grafts have dropped dramatically. So we're seeing more and more fistulas now. And they've also realized soon that as soon as there's a slight problem, they call us. So we're doing more AV fistulas, stenosis, and putting endografts, and I think we did 500 of those last year and a half last. So.
Well, Dr. Matarjameh,
Chopra,
thank you.
I'd love to be Amir, but Chopra.
Dr. Chopra, thank you for
Thank
your
you, pleasure.
contribution. And now we're going to have Dr. Hunter learn how to declot a hemodialysis graft and fistula effectively.
So I knew that Rami was coming right before me, so I decided to concentrate very specifically on the step-by-step kind of algorithm of the way that I do it and why I think that some steps are more important than others. The first thing is that most of us are not yet in big centers. All dialysis access will probably be done in relatively big centers within a decade. But most of us, I know, work in places where there's small numbers. We do our own stuff. Dialysis patients come to us with all sorts of different terms on their request, and it's very important to understand what they mean when they say something like the access is stuttering, or that pressures are up, or that they're having inability to get adequate flows. All these terms mean a little bit different to them than they would mean to us. And understanding those and getting a good history from the patient is really the very first thing that I think is important for each of us to do. And I always take a look at any studies that have been done, and just like studies on veins in the periphery, where people are always making stupid mistakes in the way they interpret them and do them, they make similar mistakes in dialysis patients. It seems like venous ultrasound is kind of a lost art in our country. And we have to concentrate on the anatomic questions they may have missed that we know that are going to be important. And it's only after I'm confident, and you'd be astonished at how much what you learn when you put your fingers on a dialysis access that even the people like the nephrologists have not gotten. Once you've gotten the information you think is important, then you go ahead and get informed consent. Because really before that, you can't give the patient informed consent about what you're going to do. And then from the dialysis access that I set up in a small hospital in Duluth where I was working for another group, the thing that totally changed the speed and efficiency with which I did it was to set up a list with my techs of everything I wanted in the room, easily available to me for every case. And they call that now the dialysis card, because no one else had one that worked there. And once it was set up, they found that they could pretty much use it with minor variations for each person. It's just like a surgeon going into the operating room and not having a card for the things that they use for their procedure. They'd never do it. They'd walk out. because they don't want to be standing there waiting, and neither do you, because, yeah, you can do it if you're all set up like Rami is to, have things running efficiently, but if you're in a place where they're not efficient and they're having to go and run and get things, it's critical. And if the nurses are having to run and go get medications that you're going to need, and they don't have the TPA there in the doses that you want, et cetera, reproducible medications, reproducible equipment, and then reproducible setup. It's astonishing to me in the University of Minnesota where I've worked, every time they get a new tech and the new tech's in the room, they get the patient on the table, they're not quite sure how to position the arm, and you get in the room and you go to do the first part of the study on the arm, just a fluoro for position, you realize they're not on the table in a position where the C-arm can get over the arm, and you spend 5 or 10 minutes futzing around getting the patient in the same position. So everything reproducible and standardized will save you an incredible amount of time. Always use ultrasound to puncture anything. I don't care what it is, even a 4-centimeter big aneurysm. Use ultrasound to puncture. In the long run, it'll save you time, and you've got to have the ultrasound on the table the way I do things anyhow. If I get stuck with my catheter and wire trying to get through a stenosis around a tight bend at the anastomosis and that kind of stuff, I don't struggle with fluoro. You can't see anything with fluoro, because you're not injecting contrast at the same time. So I whip out the ultrasound. I have someone hold the ultrasound while I hold the catheter and the wire. And that allows me to get places much more rapidly. So use the ultrasound throughout the case. And if you're going to do something that can be done very algorithmically, I would have a checklist, just like you're doing, errands for your spouse. You got a checklist. Just do one thing at a time the way you're told to do them, and that'll help you save time and energy. And then you were told about purse string sutures. Purse string sutures are nice, but I'll tell you what, the little buttons that cost nothing that you can put on there and put the purse string suture through and tie over the top of them, and I always forget the brand name of them, but it's irrelevant. They're about the 6-millimeter little blue buttons. If you do that with your purse string suture, then the techs in dialysis can just snip it with a scissors, and they don't have to be fighting with the purse string suture and digging it out of the skin if it's been in there for too long. Unequivocally, I don't use purse string sutures anymore at all, but don't use either one of them unless you're doing a graft. Don't do it on veins, because the vein is below a certain amount of tissue, and you close the skin, and the hole in the vein is still open, and all of a sudden you've got a big hematoma underneath your purse string suture or your button. Unfortunately, you got to hold the access sites if you're accessing a vein. General rules for don't doing it. Don't do it if it's less than a week old, or if it never, ever had any problems and then all of a sudden it failed. Obviously, those that aren't maturing, you'll hear about, you can make them mature. That's a whole different talk. But fistulas that seem to be going fine and then fail in the first month, or in the first 7 days in particular, just leave them alone. There's something technical that's got to be fixed. And if they have a large aneurysm, be careful of the amount of clot that can be in there. Those are the cases that really can give you symptomatic PEs. The other thing is when to stop. And if nothing's happening and I'm getting nowhere after an hour, I'm done, because something is happening in there that I'm not understanding, and I got to reapproach it with a new attitude and a new set of thinking, and so I'll stop and put a catheter in and let them have catheter hemodialysis while I figure out what the hell is happening. Have they somehow become hypercoagulable? They've got a new cancer, or something is happening that's stopping me. If you're not fixing it in an hour, I'd quit. You have to know the anatomy well. The fistulas are radiocephalic. The classic breccious amino, by the way, is this side to side. That's the way they described it. Most of them, for technical ease, are done now side of artery to end of vein. This anatomy is great because as soon as the proximal outflow stenosis hits, the distal outflow veins begin to hypertrophy, and you got these big, huge dilated veins in the hand that are pulsatile. It's very easy to puncture into the one that leads right to the place where you want to get, and you don't risk any vessels. You don't risk an arterial puncture. You don't risk screwing up the outflow vein. It's great, but there's very few done with the classic technique anymore. The one that I'm, by the way, very, very unhappy with, and we've encouraged our surgeons not to do it, is the basilic vein transposition. And that's because when the basilic vein is swung out of its course into this subcutaneous tunnel, there's a very sharp bend here where it goes back into its normal course up in the axilla. That bend is a deal breaker. That thing becomes stenotic, kinked, problematic from turbulence and intimal hyperplasia. That bend is the world's worst. I've strongly encouraged our surgeons not to do this anymore. We'll do a graft sometimes before we'll do a basilic vein transposition. If they've got the classic end to side anatomy from that most people have nowadays, I always puncture downhill into the vein. I know people encourage sometimes puncturing into the artery and doing an arterial side exam first. I think that's crazy. The risks of an arterial puncture and the potential damage to the inflow to the graft and ruining the whole thing, I think, are just, you're playing statistics instead of playing careful patient management. I just don't do it. We got to create a complete angio map, the distal 10 to 15 centimeters of the artery at a minimum, the anastomosis, the clotted segment, and then the entire outflow all the way to the atrium. And without that, you're not treating the whole patient, you're not treating all the fistula problems. You can either give a heparin bolus or not, and most of the stuff that to be perfectly honest, that I've ever learned, and I do with all my dialysis stuff, I learned from two guys who are the smartest guys in the universe about dialysis access, Tom Basilic from Mallinckrodt and Scott Teratola from Penn. I mean, those two guys know so much, it's like mind-boggling. Every time I listen to them open their mouths, I learn something new and exciting. But Scott was the one who turned me on to the fact that most of the time, because people have been sticking needles in and out of the skin to get into these things, if they've clotted, they're infected. So I've started giving antibiotics to everybody, and I've had a lot less of this kind of chill pattern going on since I started giving antibiotics to everybody. You can either give the heparin as an IV bolus, or you can give it into the clot when you're going to start to do a little bit of lyse and weight, which I also do on everybody. There's no reason not to. There's no downside risk. And I like to give the heparin in the clot because then I'm not getting any rethrombosis. Clot removal can be done simply by just sort of letting it go like Rami was telling you, but I like to actually remove it. And my favorite is the Teratola device. I like the egg beater motion. It really cleans crap off the walls of these things. And I like the way it works. You can suck out more with the angiojet, but sucking out the small amount of clot that's remaining after you've done lyse and weight, I think, is unnecessary. Unlike the 8 millimeter balloons that Rami was showing you, I like to use balloons that are only about 10% oversized, which in the grafts gives me 7 millimeters, and in the veins will put me somewhere between 8 and 10 usually. And so you can see, here's where we actually, instead of using a Teratola device, because of the tight turn, we had a tough time getting it around. We used the angiojet, and the angiojet works fine. And within a very short period of time, you've got the stenoses identified that are going to need balloon angioplasty. For grafts, I approach I'm a little bit different than Rami. For the straight grafts, I use the two-sheath technique that he was showing you, one down, one up. He was saying sometimes don't use the sheath. I like to use sheaths because it always gives me the capability of doing injections. You just can't cross them, because then you've got problems with getting the space in between them. So you got to start the punctures far enough apart so that you're looking at each other, but you're not touching each other. But with the loop forearm grafts, I've gone completely to doing a single puncture at the apex, flying up the venous side, clearing the clot out, dilating the venous anastomosis, and then going up to the arterial side and pulling the plug. So pre-procedure heparin and antibiotics here are even more important. TPA into the graft anywhere from 2 to 5 milligrams. Heparin into the graft, tight control of the arterial anastomosis so you don't push anything back into the native arteries, good control of the venous anastomosis, pulse spray or inject the TPA, massage it, work it around a little bit, don't get any back into the artery, don't get back into the artery, don't get any back into the artery. Man, that's a headache. Cross the venous anastomosis, balloon dilate it, evaluate the outflow veins. This is where I use the 7 millimeter balloon because almost all grafts are 6 millimeters. Slow, very high pressure. We use 20, 25 atmospheres, and I'm not embarrassed to do it. You cannot tear anything at the anastomotic site, believe me. You just can't do it. I suppose if you put a 15 millimeter balloon in there, you could rupture it, but otherwise it's almost impossible to rupture, especially if you're only 10% oversized. Again, the same 3 devices. Then you got to remove the plug from grafts. It's a big deal, sometimes difficult. Do not take flow as an indication that the plug is out of there. Only accept one of two things: that you've seen that there's no plug remaining on an angiogram and flow is gangbusters, or once again, you stick the ultrasound back on there, look at the arterial anastomosis and make sure it's wide open. A little bit of clot still left behind as a partial plug will give you headaches in the future and cause you to have problems with failure. Follow-up in IR is not necessary on these people. I agree with Scott Teratola about that. But they have to get surveillance in the dialysis center. Now, one of the things that Scott Teratola has actually proven in a beautiful study that he did is that if they are not ready, available, or willing to do things like flow measurements, which are the gold standard, teach them how to do a good physical exam of the fistula and grafts, and you will get just as good a surveillance with just as good a predictability as being able to prevent rethrombosis as if they're measuring flow. Physical exam has been proven to be just as good. Teratola's exam techniques, I think, are absolutely excellent. Anytime I really failed with a high-pressure balloon, I come back 1 or 2 weeks later to balloon dilate that. I always succeed. There's something about the edema that you create when you first dilate that softens things up. A week or two later, they're easy. And as always, as Rami was saying, if you have to bail out, I almost always, if I have to bail out, I don't use stents anymore. I use stent grafts because they're clearly the technique of choice. And sometimes, everything just goes great and you can't figure out quite why, but that's what the old syndrome of better to be lucky than good. My favorite better lucky than good story is about this Russian pilot who was in the Russian team of flight people that do these shows and things. And he was trying to do something close to the ground, and his engine stalled, and he had to bail out. And he landed successfully, and everything was fine. He was back up in the air 2 weeks later, and he smacked into another plane in midair. And his plane breaks into two pieces. He's ejecting again 2 weeks later, and he lands over here as his plane is landing right there, and walks away from this thing completely unhurt. And someone said to him, boy, oh boy, have you been lucky? And he says, yes, but lucky is not better than good. I'm quitting. Which is exactly the opposite of what I just told you. I think being lucky is being better than being good, but he didn't believe it. Thank you very much.
Well, I have the pleasure of giving the last two talks. So the first one I'm going to give is on the Non Maturing Fistula. The one thing is important to look into these AV fistulas is that you need to be patient, like Dr. Chopra said. You develop a good relationship with these fistulas, and then they last for a good long time, and much better than just putting a graft. One thing that I do often with patients that they don't have a good vein, I put a graft in the antecubital fossa, and a lot of times when I have problems with that graft, I just take it out and use the cephalic vein and create a new fistula or the basilic. I just want to mention with regards of the basilic vein transposition, I think if it's a technical thing on how you put that vein and you make that turn near the axilla, and I think some people make it too sharp, and that definitely it's a killer. So with regards of non-maturing fistula, a non-maturing fistula should be defined as a fistula that fails early or never develops to adequately support hemodialysis. So basically there are two problems. They're either not enough flow or the vein is too small to be cannulated. We should not forget the fact that some people have a deep vein and it cannot be cannulated because of simply of depth. The etiologies are mainly inflow problems, which are the size of the vessel, and that's a technical problem. If you chose to do a fistula in an artery that is too small, to mature, they might be able to mature, but you got to give it some more time. Then you have the poorly constructed anastomosis, which the anastomosis was constructed, and it was but perhaps instead of 4 or 5 millimeters, they did a 2-3 millimeter anastomosis. I cut myself in a technical flaw. Sometimes after I do the anastomosis, which is rounded, when I was pulling on the suture without noticing, I actually crimped the anastomosis too far, and I had to actually take them down and redo them because when I pull on the suture, I created a stenosis. So the artery can have a stenosis proximal to it, and that will affect the flow. With outflow, you can have a stenosis of the vein that has been there chronically. Remember, this patient have been hospitalized multiple times, and this stenosis can be in the vein and not be noticed during the venous mapping, and some people don't do routine venography to determine where they're going to do the anastomosis or which vein they're going to use. And the other thing is that due to cannulation, also they can have an obstruction. What I do is that before I create the fistula, I put a tourniquet in and I use a percussion test. I start at the wrist with the vein and I just hit it and go and keep going and see, because sometimes by doing that, you lose that percussion on the vein, and there's an occlusion of that vein in that segment. So perhaps that vein should not be used for that purpose. So throughout the vein, you can also have problems with accessory veins that are still in flow, or like I said, the vein is too deep. And the physical examination is the key to determine what is the problem. You can actually, with physical examination, you can actually make a drawing of what the problem is. If it has a poor thrill near the wrist, well, that should be a stenosis of the arterial inflow. If you have a pulsatile segment, there's stenosis. After that, you can listen to it and get a high-pitched bruit and determine exactly where the stenotic problem is. And you can actually see some of these accessory veins that are stealing a lot of the flow and not allowing the proper vein to mature. You can use ultrasonography, but ultrasonography is really not that much helpful on top of your physical examination. The strategies are all that we know: balloon angioplasty, stenting, coil embolization. When I use balloon angioplasty in some of these veins, you need to consider using a cutting balloon. Sometimes where you have a elastic recoil that is, and it's very hard, and you put that balloon up and you continue to pressure that vein and just won't release it, consider using a cutting balloon. I like cutting balloons for that purpose, and they actually, they have worked very well for me. I do, like 8 cuts, 4, and then turn it down, rotate it, and do another inflation. And usually with that, you get a good result. With cutting balloons, remember not to oversize. So, when there's very little data on sizes, so, and I found this paper is very interesting because they compare the non-maturing fistulas, and they compare it by size. They have larger vein size and then smaller venous size. And they found that in average, there's a difference. Of course, if you have a larger vein, you probably will require less interventions than with a smaller vein. And that if you look at these veins, primarily that are not maturing, the primary patency rate at 6 months is much better with the larger vein than with the smaller vein. But the important thing here is that at 12 months, if you do proper interventions, the secondary patency rate on these non-maturing fistulas is actually very similar if you do interventions on them. So don't be discouraged by the size of the vein. If you think you have a fistula and it's not maturing because there's a segment that is too small, go ahead and intervene on it. You might need to do a couple of interventions to get it going, but it's worth a while. So, you know, the problems, we all know you can have a stenosis at the vein near the arterial anastomosis. Remember what happens with the vein, you know, that usually nowadays most of the people do, like Dr. Hunter was saying, most of the people do end-to-side anastomosis. So there's a segment of the vein that is getting dissected, and then it's being transposed to reach the artery. And that segment usually is the one that will cause problem because of inflammation in the area. Okay, it's carrying around it, and that will take the segment and make it stenotic. So that's a very simple, because you're gonna the person will notice that there's really not good thrill. And you examine it, then you put pressure on the vein, you see it becomes pulsatile. So the fistula is patent, but there's no good thrill, and most likely that will be the problem. So that's an easy one to fix, and gives very good results. Another problem is the vein. Sometimes, you know, you have this fistula that has been working well, and it's been having a good thrill, and slowly it started losing his thrill, and it become pulsatile. So you have areas, like I said before, there are areas where people had been cannulated previously. One particular area is the antecubital fossa. I have that problem all the time, you know. People go for blood draws, and it's consistently they will go for the antecubital fossa, the phlebotomies. So, you know, these veins are sometimes they have stenosis, and they might be a problem. And then what you need to do there is very simple. You know, you use angioplasty and wait, and the veins will dilate. Okay, that scar tissue is not that bad. See, here's a good example of a vein that has a small segment that is tiny. Okay, that one, it was dilated, and it actually became a good fistula after all. So sometimes you will get this fistula that was working well, and for some reason, maybe they grabbed something with their forearm and it got occluded. Don't, you know, it's not being used yet. Well, we shouldn't get discouraged about this fistula not maturing, and, oh, it got occluded. You know, you can declot it and get it going. Like in this case where you cannot see clearly where the vein is, but this is the anastomosis, and it gets really small, and then there's a good segment of vein going this way that you cannot see, okay? But, you know, after an intervention, you can see how that's actually a good vein, and it only had a stenosis in this segment. So don't think that if it fell early, necessarily it's not gonna be a good fistula in the future. And here's a very common problem. We see a lot of people that, you know, it has a good thrill, but the main vein is not maturing well. Well, I'll tell you that, and you can see all these accessory veins that you take them out. When I construct fistulas, what I usually do is that I see, if I see a big vein that might become a problem in the future, I just ligate it before I finish. It takes an extra 3 minutes, and it will avoid to have to intervene in the future. Okay, so here's a coil embolization of the branches, and it provides with good results. You make the flow go through the main vein, and hopefully it will continue to dilate. Okay, and for the last issue with the fistula not being able to be cannulated is when they are too deep. So, you know, you see this lady, she was obese, her arm was huge, and we did a brachiocephalic fistula at the antecubital fossa, and she had an excellent thrill, but the only segment that was visible was right here at the elbow. Then the rest of the fistula was very deep. So what I did with her, I made a little incision here, and then I got the whole vein just right under the skin, and that fistula was, you know, after 6 weeks, they were using it, and it was a good result. So, you know, size can be fixed with intervention. You just have to be patient. Stenosis can be fixed with angioplasty. Stenting might be necessary. I won't get into that. You know all about it already. Accessory veins, you can coil embolization if you need to. You can, 3 millimeter, 5 millimeter coils. That's all you should need. If there's like really a larger vein than that, you might consider ligation, which is not a bad option for these people. Ligation is done very simple, but if you're not comfortable with putting a big coil and leaving it there, just send it to ligate. And then if it's too deep, it can be brought near the skin to be used in the future. So I don't see a deep vein is not a contraindication for an AV fistula. Okay, I think that shouldn't be done. You should not put a graft where there's a vein because the vein is 1 centimeter deep from the skin. I don't see it as a correct decision making. So, any questions with regards of that? Yes. No. Snuff box. Mm-hmm.
Shear forces, the hoop strength, and the way that trigger looks at the anastomosis. So that's, I think prevention of JAS is very important to talk about. I think the second thing that I encourage everyone is when you go in surgically, you look at a juxtanastomotic stenosis, it's very thick. The vein is almost occluded. If you think you're going to fix a JAS with a cutting glue or angioplasty, the success rate of that is very low. You want to do local interventions, you can damage the artery proximal or distal to that, and the fistula will be shot. In fact, I've got
Well, any other question? Well, let's go on treating aneurysms of arteriovenous fistulas, you know. So first, you need to understand that the reason why these veins dilate is because that's the normal response of a blood vessel to flow. They actually increase in size due to the increase in flow, and that's the expected response for a fistula when it gets formed. So there are other issues like post-stenotic dilatation. You can see some areas where it dilates, and then on the other side you develop a small aneurysm. And then the main problem with fistulas these days, I believe, is repetitive trauma. They keep poking on the same spot over and over and over again, and that's a fistula that you see, that you have a fistula, a big aneurysm here and a big aneurysm here, and they continuously go for the same spot to give him dialysis. Right there in the puncture side, the vessel wall becomes very thin and weak, and that continuous puncturing just creates the basis for the area to dilate. So you can also have outflow stenosis. That's very important because now you have a vein that it's weak, and on top of that, it's sustaining arterial pressures constantly, and this will also lead to extravasation. So when I see a pseudoaneurysm or a big hematoma in the arm, what I usually think is that there has to be a venous outflow stenosis. Usually with an open venous outflow, you're not going to get a pseudoaneurysm on a fistula. It will bleed a little bit and then it will heal. So lacerations, when you have a longer tear, that's a different problem than dealing with a small hole that has created a pseudoaneurysm. And once again, repetitive trauma with the wall thinning and the weakness of the vein that will create the aneurysm, make it bigger. So one thing I can say is that looking into it, the data on how to deal with this is scarce. There's not many, there are no randomized trials that I saw comparing endovascular or open. So there's a bunch of case reports and a case series. I saw a case series that included 13 cases, and it's in the internet, but it's not even published. It's somebody speaking of his experience, and it's on a PowerPoint presentation. So, you know, at best we can say that this data is anecdotal, and that's what we have. So it's difficult to come up with, you know, with good recommendation on how we should deal with this. So this is a fistula, you know, and this is what you expect from a fistula, that it will grow to this level. Some of them will grow even larger, right? Like this gentleman. This is just a vein that's probably been there for 18 years, 17, 20 years, God knows, and this continues to dilate slowly, but, you know, surely. This is another example, and you can see on this gentleman how he has all these areas that he could be cannulated, but they will continuously cannulate here and here, okay? So the question is, when I look at this, okay? So this appearance, is this dangerous? Should we treat this? I mean, is this an aesthetic problem, or the patient is in real danger? Well, I'll tell you what. The first thing I'll say is that the most important thing is the clinical presentation. You know, when you see somebody with an aneurysm, you should ask whether there was bleeding, whether this is having trouble sealing, you know, when after they get the cannulas out, with continuous bleeding, well, there's no bleeding, okay? Are there signs of infection? If there's signs of infection, it's definitely a problem. You should look into it any further, okay? Are they having problems with pressure during dialysis? Are they reporting recirculation in the circuit? Those things you should ask, like Dr. Hunter was saying. Maybe these are the things that you include in your dialysis card, some of them, right? I think this is important that you should listen to it. And then, of course, when you do the physical examination, I'll tell you that I look at skin characteristics as my main thing to decide when I'm going to intervene on these patients. Because if I can pull on the skin and it separates from the vein and the skin looks good, then, this is an elective case completely. But when I see a thin, shiny skin that doesn't really separate from the vein, that's a problem. That you should fix. You should not leave that just like that. And those are a problem that need fixing, but most likely it doesn't need fixing tomorrow. Okay? And then when you see a necrotic skin, you know what? You should consider that case sort of like in an emergency basis. You shouldn't just post them for next week on Monday, because necrotic skin will rupture. It'll lose its tensile strength and eventually they will bleed. So if you see visible bleeding in the area, you might consider that a problem. Fresh thrombus cap, a pulsatile fistula with a fresh thrombus cap that is coming in and out, you should fix that immediately. The one thing about fixing aneurysms is that you should do a fistulogram and make sure that if you have a venous stenosis, it gets dilated. It's part of the problem on why they develop these aneurysms sometimes. So you have to make sure that if they are really pulsatile, you might want to stage, then fix the stenosis first, and then take care of the aneurysm. Well, like I said, when I'm looking at this gentleman, the previous gentleman who had a large aneurysm, I think that needs fixing, but I'm not too concerned. This gentleman right here, you see, with the skin is thin, it's dilated. He has some areas that were bleeding. It's very dilated in this specific area for the same reason. Probably the vein is not that good up here, and they continues to poke that area. So this case, I consider something that should be done soon. Not tonight, but perhaps during the next couple of days. But when I see something like that, it looks infected. It has cellulitis. It has a necrotic cap. There's visible bleeding. That I consider an emergency. That I will not leave for the next day. I will try to fix it as soon as possible. So, infected aneurysm, lack of skin integrity. Is it dangerous? Should we treat it? I consider a medical emergency. Those patients should be treated immediately. And that's one case that I probably rather do open instead of putting an endograft, because I don't know. I always feel that if you put an endograft in an infected area, you can develop problems in the future. So the options, you can do endovascular. You can put an endograft to treat the aneurysm. You can do thrombin injections. You have a pseudo aneurysm with a small neck. You can do thrombin injection and just leave it and see, and a lot of them will reabsorb and disappear. Okay. Then you have the option of surgical repair, resection, or plication. You can either take it out or just put a couple of sutures and make it smaller. If you do that, do the plication to the side, so when it scarred down, the main area that will have the flow will still be close to the skin. And you have the options, the other options that are combined. Like I said, you can do the fistulogram with the angioplasty to relieve the venous outflow stenosis, and then followed by the repair. When you're considering of fixing an aneurysm, you need to think, is that fistula is going to be usable after you're done with it? Well, if it's not going to be usable, then you should perhaps put a tunnel catheter in preparation for the repair. Okay? You do the dilation of the stenosis previous to the repair. Then consider preoperative antibiotics, like he says, especially if you're fixing a graft or you're intending to use an endograft. And then, if you're dealing with a graft, per se, not an AV fistula. Those have a whole set of particular considerations that you need to take care of. So let's see. You see this. It's coming into your office. Who will fix it open and who will fix it endovascular? Let's see. Who would like to just cut it and put a couple of sutures into this aneurysm? Okay. How about who will do an endograft? Who will put an endograft into this? Who will just leave it alone? Okay. So here's that gentleman. He got an open repair, okay, and the result was good. He had the fistula fixed, and I think that was the appropriate decision for this guy. And there's different ways. You know, what I usually do when I have a case like this, I take one area at a time. And sometimes that had worked for me. If you had 3 areas that are big, I take one area, it continues to get his hemodialysis through his fistula. Then once that's fixed in 6 to 8 weeks, then it can be used, and I go to an next aneurysm, which is it's a good strategy. It's a strategy that has worked for me. Okay, and here's a good example of putting an endograft. You have this big fistula, you know, it had a huge aneurysm. It had some areas dilated all the way down to the arterial anastomosis, and they did the endografting, and it actually shrunk that down significantly, and it continues to work, and they didn't have to do anything else with it. That was And here's another one. This person had a pseudo aneurysm because of a laceration, and they put a Biovan in it, and it worked very well as well. And so here's another example of what an open repair is. I'll tell you, this type of revision I don't like. I give you this example, but usually what I do when I see an aneurysm like this, I just make an incision on the top, and I dissect the aneurysm. I get proximal and distal control, and then I just take a piece out and close it and leave the remaining vein usable for his hemodialysis. On this individual, apparently they revised the whole thing and they did something else over here. It's not the... So let's see over here. This one had some necrotic tissue in this aneurysm, and the other one looked good, but you know, they took him to the operating room and fixed the whole thing. Okay, so that's a good option. So in conclusion, I think that clinical presentation and physical examination will determine specifically the timing of the operation. Once you see the patient and listen to what's going on, you will decide when to operate. And then proper assessment will help develop a most beneficial strategy. You might, like I said, if you might want to do the fistulogram first, do the angioplasty, then take care of the aneurysm. If you think that the fistula will not be used after you're done fixing the aneurysm, you might want to put a catheter in, and all these things need to be considered in order to maintain the patient, you know, as well as possible. If it's a localized aneurysm, I will say that endovascular is superior. And most likely you do percutaneously, and that's it. If it's a large diffuse dilatation, I will probably recommend that the patient be treated with an open repair, and keep in mind that you might need a catheter placed previous to that. Thank you.
I want to thank you, Dr. Trabal. He came from Puerto Rico and shared all this with us. Thank you very much for participating. Thanks, Dr. Hunter. And thank you, Dr. Chopra left. Dr. Ossie's still in the audience. So thank all the faculty, and thank the diehard participants that stayed here. And I know that the quality of the speeches today, or the teaching today, was excellent. So for those who stayed, it's to your benefit. I know Dr. Berg is from Iowa. You're from Emory. So I just really appreciate the fact that you stayed and asked all the questions. And I know there's a small group of people, but it's been a long 3 days. And I wish everyone a safe travel home. And thank you very much for being here. Thank you. I want to thank our audiovisual people. Thanks for all the help, guys. And particularly for the large red arrow. That was great.